now, just keep your questions there right at the moment, because I'm going to ask our panellists to come and join us on the stage. So I'm going to have to ask Professor Meier to come back up again and Simon Waring to come back up again. And then I'll introduce the next panellist, who is Dr Carolyn Lethborg, Clinical Leader of Cancer and Chronic Illness at St Vincent's Hospital. Catherine, where are you? There. Dr Lethborg is a social worker in the end-of-life setting, and she was working for 25 years with people living with cancer and HIV/AIDS. Her PhD studies were then developed into a meaning-based therapy for the palliative care setting, and it's been trialled at St Vincent's Hospital, Peter Mac and Cabrini-Paran. Dr Lethborg is a clinical leader in social work at St Vincent's, and she's a specialist counsellor for the Breast Cancer Network and an honorary research fellow in psycho-oncology at Monash Medical Centre, Peter Mac and the University of Melbourne. Please welcome Dr Carrie Lethborg. Sitting next to Dr Lethborg is Associate Professor Mark Boughey, who's Director of Palliative Medicine at St Vincent's Hospital, and he's Co-Deputy Director of the Centre for Palliative Care. He's also Chair and Clinical Lead of the Victorian Palliative Care Network and Chair of the Health Renal Conservative Care Working Group and the Victorian Aboriginal Palliative Care Collaborative. Associate Professor Boughey oversees a broad range of palliative services, research, training and education. He mentors emerging palliative medicine leaders in developing countries and is involved in local, state and national service development in Australia. Please welcome Associate Professor Boughey. Then we have Professor Meier, as you can see, and then our next panellist is Carmel Smith, who's Executive Manager of Goulburn Valley Hospice Care Service, Inc. Ms Smith is an experienced registered nurse with qualifications including a graduate certificate in cancer nursing and a specialist certificate in palliative care, and she's an accredited breast care nurse and a living with cancer facilitator. Ms Smith was responsible for establishing oncology services at both Echuca Hospital and Shepparton Private Hospital, and she set up the local breast cancer support group, which continues today. She was awarded life membership of Palliative Care Victoria in 2015. Please welcome Carmel Smith. And there we have Simon Waring, whom you've already met. I'm just going to start by asking one or two questions, but really this is for you to ask your questions and to get the conversation going about the things that really matter to you and that you want to know more about. So I just wanted, so that we had a sense of our new panellists whom we haven't properly met through conversation, I thought I'd just ask, starting with you, Carrie, what do you think the major problem is with palliative care that really needs to step up?
I think one of the issues is what our definition of success is when we're caring for someone. And if our definition is to do as much as we can medically to focus on cure, then we are losing the picture of what actually patient-centred care is. And I think that's difficult for our medical colleagues who have been taught that that is what the definition of success is. And so there needs to be, I think, compassion for staff that we work with as well as for patients and families, because this is the great leveller. This is confronting for all of us because we've all probably experienced loss, and we've also had to face the possibility of suffering. And I think, suffering is a part of living, and we can't always take all suffering away, and we need to just be comfortable with that. What we can do is provide so much support that we rebalance things, so even in situations that feel extremely difficult. So I think that's one of them, one of the issues.
Thank you. And Mark, as a clinician, what do you think is the single most important thing that's lacking?
I think from my point of view, certainly, the innovation and advances in medical surgical care, certainly there's real sense that treatment and the offering of treatment is the representation of care, and I think we have disconnected a little and forgotten that it's all the other elements that come under that sort of banner of palliative care that actually connect with the patient at the same time. And so there's a sense that somehow interventional approaches is good medical surgical care, and we forget the other side of the equation until it's a situation where people are feeling much more burdened because people are withdrawing care, because they're withdrawing treatment. So there isn't the connection that sees them through the whole journey. And again, as I think we heard, the referral to appropriate care at the right time becomes the exception, often without question and without demand for those services.
Yes, thank you. Professor Meier, you did identify people having to know to ask for it, and the better education of the medical profession. What else comes to mind, and if you've had long enough in Australia to see what you think might be more of a problem here?
I think I'm a broken record on this, but it is understanding that palliative care is good medical care and that it should accompany all medical care, whether you can be cured, whether you can live for a long time with a disease or you have a progressive illness. Every clinician should have that skill to manage pain and other symptoms, to communicate and explain what to expect, to determine from patients and families what's most important to them. It is not about, or not only about, end-of-life care. That getting that point across is like a revolution. It's about bringing medicine back to its roots. Who is this person in front of us? What is most important to them? How can I help them achieve it? Why should that be something you only get in the last few days of life?
Carmel, is that your experience coming from the nursing background, that this sort of resistance to seeing it all as connected, is that what you're feeling about palliative care?
I think it has. I suppose I've been nursing for a long time now, and I've seen a change probably in the last 10 years with the emergence of palliative care as a specialist area of medicine, but it doesn't go across the board. And I suppose I'm from a regional centre, and we have some very good doctors, but we have some who are the same as everywhere else, who do not know how to have conversations and don't know how to communicate. And I think in palliative care, that's the biggest skill that you need. You need the time to sit and talk, and you need colleagues to accept your expertise and the work that you do as being valuable and value added.
And Simon, you've spoken very eloquently about your experiences. It seemed like you did get, you were able to have very good palliative care in your family. What would you say was the hardest part of getting that care, or what was lacking? Was there anything lacking that was hard for you?
Well, I think what was challenging was, admittedly, we're dealing with children, and that can be an issue even for very experienced professionals, because they feel they lose their skills when they're dealing with a child. But I had palliative care nurses coming into the house, and for the first day or two, because we go, oh, great, come in, this is what Marmaduke did, we'd be giving them lots of details on his medications, but they wouldn't come near us for a cup of tea or a biscuit, and we couldn't work it out. And then after about 2 or 3 days, I realised, they said, when they go into a house, and often that's for an adult patient, there is so much stress because they often have to try and find one confidant, one person they can try and get information from, and they have to create a fictional reason to go out to the rubbish bin to get an update on the patient, because so many family members are in denial. They don't want to know if someone's, oh no, don't want to look in the room. And so we were actually being incredibly honest and say, oh, well, this is what happened. And eventually that broke down and they did relax, and that made a massive impact. And I think we're all human, so there are challenges for everyone dealing with someone who's dying, even the professionals, which is what the panel's been saying.
Thank you. Well, I'm sure there'll be lots of questions. We do have roving microphones, so if you'd like to indicate to me if you've got a question to ask, wait till the microphone gets to you. So there and then there. Thank you. And direct your question, make it sure it's a question if that's okay, not a statement, and if you could direct it to a particular person or to the whole panel.
I think to the whole panel, it sounds so sensible to me. I wonder, does it need legislation or is it training? How can we make it so the uptake is as fast as possible?
Well, we can start with you, Professor Meyer, because you've probably done a lot of this change. You did a lot of that change in those early days in the late 90s, didn't you?
Yeah, that's my favorite topic. Thank you for asking that question. Yeah, policy is critical. Legislation, regulation, accreditation. So government has a huge role to play here, both at the Commonwealth level and at the state level in Australia, by, for example, saying that we are not going to accredit a medical school or a nursing school that doesn't graduate clinicians with demonstrable competency in communication skills, in pain and symptom management, that you will lose your accreditation. Similarly, it should become a quality standard that every hospital, every nursing home, every cancer center, every dialysis unit has embedded within it palliative care capacity, whether because they've trained their own staff to do it or they bring in palliative care experts, and that they can't be accredited or reimbursed unless they're demonstrating that. As you said, it's very sensible, it's very obvious. The data are clear, it helps people enormously, it prolongs life, it reduces cost. What is the problem here? Why can't we just make it the standard of care? And it won't happen without a nudge from legislators and policymakers, because that's what drives the standards and the behavior of organizations and clinicians. So thank you for asking that question.
Mark?
Could I just add as well that certainly behind the scenes for people who work in healthcare, there is a lot of activity at a government level in Victoria, a lot of activity in the hospital system at the moment around uniform standards, around palliative care connection, around the whole trajectory of deteriorating patients moving towards obviously eventually dying over that longer time frame. So there are a lot of work is happening. The hospitals in Victoria have formed an acute health collaborative around this work. So there's a whole lot of activity, but may not necessarily be visible to the public at this time. But people in the audience may be aware of the Legislative Assembly process that's going on at the moment, and also the election platform of the current government is around expanding and looking at the whole sort of end-of-life trajectory from the early days of advancing disease right through to dying. So
And
quite
see
a bit
you
of
nodding,
activity.
Carrie, too. Is this your experience?
I'm sorry, can you say
Is this your experience? I can see you nodding. Is this your experience too, that things are changing behind the scenes, that there's a clear recognition?
I think, communication skills training was, I remember I started doing that with medical students 20 years ago, and it wasn't until we had it as part of their exams that they actually had to pass, that they came and listened, and we knew there was an anaesthetist in every group, and that was okay because they were really good technicians. Nothing against anaesthetists, but there were some that were particularly found the whole communication part very difficult. But I still have heard of young doctors being the ones that are nudged to go and break bad news and say that someone's son has just died, and no one's actually told them how to do that. And there is still some of those experiences going on. What we know now is that we can measure that people that have had communication skills training do so much better, and their stress levels as clinicians are much lower. So we know quite a lot about that now, and we are actually giving those skills. These are not easy conversations to have, and there are tools that we can actually be passing on, and I think there's some really favourable things happening.
Mm-hmm. Fantastic. Okay. Next question was the gentleman here.
Yes, I'd like to wish the panel good luck in getting the medical profession in Australia to embrace the new definition of palliative care. It it seems to me, and I've had an experience of this myself, that you get diagnosed with an illness, let's call it cancer, and you get onto a treadmill that you can't get off. You go to a specialist who recommends this, that treatment, and then that operation, and then that test, and then that treatment, and you go on and on and on. You can't get off the treadmill. There must be a way of having patients have a little bit more assertiveness and input into their own treatment somehow. I don't know how that could be. I'm maybe going to upset a few oncologists here by likening them to a general in a war who finds a cell of rebels or infiltrators, and they go in and they try and kill as many of them as they possibly can. And if they do manage to get them, they call it a success. But all the collateral damage, the damage of innocent people, the buildings, to infrastructure, etc., doesn't seem to worry them so much. And I think that is one of the side effects of cancer treatment is that. And I was just going to ask, we talk about here palliative care being improvement in quality of life. Is there anything available which improves the quality of dying?
What was the question? Is there anything available
that improves the quality of dying?
Okay. To the panel? Simon?
Well, I'd actually respond by saying the palliative care in itself is improving the quality of dying. Certainly the support, the ability to remove the pain and then also find other levels of comfort that removes, as the professor said, the tension, the stress, all of those absolutely improve the comfort of the patient. From what I can see, I'm not a professional, but I know that there were times where statistically, Marmaduke was gone, or he was dying, or all the signs, the nurses would come in and they'd say, even a few days before he was dying, we're really concerned, he's unresponsive, he's gone. And his sister would just lean over and whisper something to him, and this voice would come booming back from this apparently dying child. There was another moment where the nurse was really concerned about unresponsive and have you last heard him speak, and I just leaned down and I used to tickle his cheek when I kissed him, and I just kissed his cheek, and his face just creased in this enormous smile. So is that relevant? Only that I think underneath he was in a very warm, safe space, and so he could hear the voices. He may not have been as physically strong, but I think the environment and the lack of pain and the comfort he was surrounded in was a bit like a cocoon. And that I can only put that down to the support we got and obviously the approach that we were able to take. It's always you're managing a combination of sort of luck and judgment. That absolutely improved the quality of his death.
And Carmen? Carol?
I think that with the oncology question, and I totally agree with you, and I think that that's one of the ways where palliative care is walking alongside oncology through someone's journey from diagnosis, how we can make a difference. And I think we do that by empowering the patient and their family, by having those hard discussions with them and saying to them, all right, we're going for, this is your 5th lot of chemotherapy. What do you think your response is going to be? Because what I find is that a lot of the oncologists talk in percentages and people don't understand that. A 10% chance of response might mean an extra 2 weeks of life, but they might be miserable for 6 months. So I think that we make a difference when we're with those patients in having those difficult discussions, as you said, and being able to sit with that family at home in the comfort of their home and in the quietness and say, all right, let's put all the cards on the table. If you do have this extra chemo, what difference is it going to make? And I think that's a skill of palliative care, that is probably would make a big difference. And I guess around the making a better death, people always talk about a good death. I don't know what a good death is. I think, and I deal with this every day in Shepparton, we have about 120 patients die in our books every year, and the majority of those die in the comfort of their own home, and we're very lucky that we've got a service and a community that supports us to do that. But it's never going, we can never make that end any easier. It's still losing someone that they absolutely love, and even though sometimes we think that that patient died well, it's still, you'll talk to families afterwards and they'll question it and they'll say, well, why do you think that happened? And, you know, mum was groaning. But, you know, if you're able to explain that process to them, it prepares them and it makes it easier.
I think also there are increasingly triggers in the system. So people often use advanced care planning, but advanced care planning is a trigger to empower people to at least raise their voice. I think, as Diane mentioned, the more public engagement allows people to actually voice their wish to have communicated to them in a different way. I've been with a dying patient who demanded of their oncologist to communicate in an effective way. When he was playing with his mobile phone one day, the oncologist looked at it and the patient said to him, "Are you the right oncologist for me?" Because he wasn't paying attention fully to that patient. So there are ways to actually get oncologists' attention that you can be empowered to do. But I think key to this is that if you connect earlier to a more holistic way of care, whether that's palliative care and an oncologist or oncologist who can take that role as well, is you get to tell your story in some way, you get to feel valued, you get to feel connected, and it's in that process, as well as good symptom management and all those other more pragmatic things, is that people feel safe and they can move into dying in a sense of safety and connectedness, which allows for what you may call quality of dying in some way. So that would be my kind of take on it over many years of watching these things sort of play through.
Okay.
One thing I want to say, having worked with oncologists for 25 years, I have sat in the room with many of them who have worried greatly about offering more treatment. I've absolutely had to sit down with some and say, you know, where are we going with this? But I can tell you that it might come across when the decision, there's an offer made, but as just a fait accompli, we've got this other treatment, but I certainly have sat with many of them who have worried greatly. And I guess one of the things that we need to be doing is hearing what each patient and family are wanting, and some people do want more and more treatment, and so we need to continue to have that conversation. That's just one point that I was thinking. The other thing is, you deserve second opinions if you want one. You know, certainly the medical stuff I've worked with, I've always been happy to give a second opinion and to have patients that they are seeing to go and have a second opinion, even if it just confirms that where you're going is the right way. So if we're talking about very serious medical situations and you're not happy and you don't feel like you're being heard, then you need to demand that you are being heard. I know it's not easy, but I've certainly heard many patients say to me, I don't want to upset my doctor. What will they think of me? I can tell you it's absolutely fine to do that, and if it's about just peace of mind that you know where you're going, please always feel you can go and get more information. And just one last thing, I was thinking about Marmaduke and how when you have a child, the idea of getting in bed with them, physically holding them, or even just holding that person in that you are making sure they feel loved and significant. Sometimes it might be easier to think about that kind of care with a child, but in the end I think it's possibly what we all want. We all need to be held and to feel loved and to know that we matter and we're significant. And I see that every day in the hospital setting as well as outside of the hospital setting. I see nurses who go the extra mile. I see family members who come in and put pictures up all around the room so that we all know who that person is. And that kind of care can happen anywhere. And us, as adults, we're not so good at asking for that, but that's actually what we all need. So I'm going to keep Marmaduke in my mind of him being in bed and his sister in there and his toys, because really that's what we all want when we're in this situation.
Just wanted to add that not many of us would get on an aeroplane that had a 10 or 20% chance of reaching its destination, but we embrace chemotherapy with almost those same chances, and perhaps it's their duty to look after, make sure that journey is as pleasurable as possible before the plane crashes.
Next question, over here.
I'd like to invite the panel to comment briefly on the economics of palliative care. And I guess just to make a big question even bigger, I'll ask you if you might come at it from either of the two ends. One is the industry scale. Is this new and productive stream of medicine simply going to be another drain on an already stretched public purse? Or perhaps can it be a substitute, and can we divert resources perhaps into a more efficient area? But the other thing is also at the personal level. If I need to arrange palliative care for me or for a loved one, what does it cost? Who pays? What will it cost me? How does it work? And I guess that's probably in an Australian context.
Excellent questions. Okay, we'll start with Simon.
I was actually going to say, when the professor was talking about influencing government and getting government to make the change, I was going to say, to borrow an American expression, do the math, because if you empower, I'm not saying it's one size fits all, but if you're empowering a family to look after a patient, and so if we take Marmaduke's example, a nurse was visiting for maybe 40 minutes or half an hour a day to change the drugs, because we weren't allowed to change the drugs, and check the driver, and that was it. We had equipment supplied, so there was effectively a hospital bed and some other equipment just to make his life comfortable. But other than that, if he was in the hospital, that would have been 24/7 care for anywhere from 5 to 10 weeks. So yes, there undoubtedly must be a cost to have the mobile services and the rental equipment available, but compared to taking up a hospital bed at goodness knows what cost per hour, it seems, if we're talking carrots and sticks, that's a lovely carrot for government to look at.
Mm. I was going to comment that there was a very good paper from Stephen Duckett from the Grattan Institute, who is the architect of Medicare, was the architect. Anyway, he did some costings, didn't he? I know, Mark, you'd probably all be aware of this paper, where in fact it saves a lot of money, but then there's costs involved and it comes out more or less equal, I think. Does it? Is that?
Well, it again is the sort of scaling of the cost, but I think anything that is able to focus on a community focus rather than an inpatient focus is going to, by result, be a lot economically more sound. I think the shift has to be, though, that we are most probably in a context of specialist palliative care, taking a kind of leadership role, but we need to diffuse the whole sector. So it should be routine care that most people should have in healthcare have some connection to. So you're empowering not only the healthcare professionals who aren't necessarily the specialists, but you're empowering the community nurses, you're empowering the local community. So in Shepparton, where they have such a success rate in their patients being at home, it is all about community connection. A lot of Indigenous communities don't have the specialist care, but they have a very empowered local communities that take charge of the process. So in that, it becomes a much more economic viable process.
Carmel, can I ask you, what are the economics of how you provide such a high level of palliative care?
Because the community raises the money for us to do it.
Oh, really?
So, yes. So we get government funded, but the community raises, and we've been in the town for over 26 years, so the community has an expectation that when they need us, we will be there, and so they raise money for us, and we have an opportunity shop if any of you are in Shepparton, which is
It's
a
by the
wonderful,
front door.
wonderful.
You can't get out without buying something.
The op shop is a wonderful extension of our service, and it raises, as well as raising a lot of money for us, a lot of the people whose partners we've cared for give time back to the service and time back to us by volunteering there. When somebody they love dies, they'll take their, their belongings there. It's a really holistic area, so they're looking after us all the time and raising money for us. So I think with most of the community palliative care service, there's no cost. We're on call 24 hours a day, 7 days a week, as are most of the community palliative care services. So if the family falls in a heap in the middle of the night or if something happens, we can go out for a visit. But our workforce is you. Our workforce is that family unit, and we can be there once a day or twice a day, but in the end it's them that are doing the work 24 hours a day around the clock, and they are amazing. They are amazing. They become mini professionals in what they do and how they help that loved one to achieve their aim to die in their place of choice. And it's not always home. Some people want to stay at home for as long as they can, but then want to die in hospital. They don't want the memory of their death in the home. So that's another area it's our place to make that call when it's time to make that move. But then we want the confidence to know that when we're moving them into the hospital or into a respite bed, that they're going to be as well cared for in there as they would have been at home with us. So we follow them into that situation and we follow that family.
Yes,
Can I
Carrie?
just say, one of the things that brings up for me, I guess, is the cost to carers and how exhausting this actually can be. And Simon talked about the what I would call, preventative care in terms of the bereavement process. We know when families, after families have cared for someone who has died, that they meet grief, which is exhausting in itself, already exhausted. And I think, we actually underestimate how much carers do save the government and save in terms of services, but we need to be very careful, and we need to be providing as much support to them and giving them breaks so that they actually can then go through the next stage, which is another big stage, as well as they can.
Diane, can I ask you, you've obviously been working in this area for a long time to change the definition and the practice and the availability of palliative care. In the sort of strategic things you have done, has it involved legislature and policy and all those things as well, or goodwill of people?
I don't know if anybody reads the newspapers, but our government is not very functional these days. So I was naively optimistic that legislation would be the answer. I think it's more complicated than that. I think there's actually more power in regulation and standards and accreditation that drive healthcare organizations, wherever they are, and the people working in them towards a common shared standard. That doesn't really require legislation. That requires action from the Ministry of Health or the regulatory bodies. What does it take to change the requirements for medical education or nursing education? That's not legislative. There's a body that determines what medical schools have to teach. It's influencing that body. But I want to add to the point about cost, because when governments add up cost, they only add up the cost that they pay for. It's either the government or the insurance company's cost. The family's cost is invisible in these analyses. And family caregivers, the estimate in the United States is it's over $500 billion a year in uncompensated care from family members. So I would argue that governments cannot afford not to provide enormous support to families who are delivering this care. It is the exhausted families that end up calling 911 because they're not getting the support they need. Families are the linchpin of the entire healthcare system across the globe. And as I agree, families are remarkable in their resilience, their courage, their love, the sustained care. You saw Simon's film that they provide. But it comes at a cost that we don't count up. Not just dollars and cents. Simon wasn't working when he was a carer. You must have had alternative sources of livelihood. Most people don't. So, either the patient is the major breadwinner or the family carer is the major breadwinner. The leading cause of personal bankruptcy in the United States is serious illness in a family member. So we have to think about costs in a more holistic way. And that's why I want to reinforce your point that there's no better investment than in supporting the family carers in the community.
Can I just throw the last part of that gentleman's question to you, a very pragmatic one, is in Australia, how do you get this care? Who do you ask and how much is it actually going to cost you, a patient? Who would, Mark?
Well, there's a lot of mechanisms, and it is readily available, and per se, connecting to it in Australia is relatively straightforward. That you can either do through your own hospital, where you might be being treated, and you may connect to a palliative care service, a consultancy service in the hospital. You may be at home or thinking about this, and you can ring something like Palliative Care Australia, which is the national advocacy organisation for services and for the states. So Palliative Care Victoria is the equivalent in Victoria. So you can connect to their websites and ring them, and you can find your postcode and find your service. You can also be referred directly or indirectly for other healthcare providers. There's a whole sort of network there to be referred to. You can look on the Department of Health and Human Services website to find those connectors. The connecting can happen. It's then the access issues sometimes become the hurly-gurly of getting over the barriers. So rather than being the exception, you need a healthcare professional sometimes to help negotiate at the moment some of those concerns and barriers. But it is potentially readily available and accessible.
And Medicare
My only area of concern is in the more privatised hospitals, so the private system. Some of those connectors don't add up because it's a much more doctor-driven system, and if the doctor doesn't suggest it, it often doesn't happen. And so the holistic nature of care gets missed sometimes until a more crisis point can be met. So sometimes that is an issue, I think, the uniformity across our two systems.
Thank you. All right. Next question. Here and then there. Gentleman in the red shirt and then the lady with the green dress on.
Thank you for the panel for promoting this discussion. It is complicated, and Mark, your observation about the access, I think, overstates the way most people see palliative care, because it's something that comes to them without preparation. I'd like to ask the panel about the locus of control and where the discussion of palliative care and end-of-life care should occur. And I'd like to prompt it, should it occur at the primary healthcare level? Should it occur at the secondary education level with some specific teachings to touch on death? And so the conversation gets introduced at the family level prior to the stress of being diagnosed with a terminal illness.
Thank you. What an interesting question. Panel, who'd like to take that first? Oh, I can see there's resounding enthusiasm for this.
So there are pockets of light in the States on this, where high school students, for example, have a required course on serious illness and end-of-life care, and they work in hospices in the community, and they each establish a relationship with a hospice patient and visit them at home and get to know them as a human being and get exposure to, the profound privilege of caring for a seriously ill or dying person. And there have been some videos of these high school students talking about, just as Simon's daughter said, it totally changes their appreciation for the preciousness of life, for authentic relationship, for the infinite value of relationship. So it can happen. The question is, how do we standardize it? But I think it's very powerful to reach people when they're young and healthy, and as Simon's children got to see, but everyone should. It's a great idea.
People often talk about health promoting palliative care, and La Trobe has a big focus on trying to reach that more broader kind of public arena, as well as many other mechanisms. And I think certainly, you can find countries, particularly say the Scandinavian countries, where they have built programs from primary school up, and the conversations around death and dying are much more openly sort of raised. I think we tend to treat it a little bit like, or not even learning how to drive a car for our younger people, but we kind of know it's going to happen sometime, but it's not until we're right at the point of kind of going to crash that we actually start thinking about dying so much. And I think that's a disservice, and I think what we've heard about tonight is that we want to bring it back earlier. So we should see brochures in our waiting rooms. We should see on the Clinicians Health Channel kind of relays about talking about these things, but we don't necessarily see them. We don't see, you'll have hospitals that won't have brochures around palliative care sitting in their outpatient clinics and things like that. So there's ways of systematising the conversations in a much more ready way to do, I think. Connecting to, we have a big program around organ donation and licensing and driver's licenses, that there must be other mechanisms we can connect conversations around death and dying and empowerment to other arenas like that. So I think there's a lot of opportunity. It's just getting the systematised way of operationalising it.
Simon.
The word Mark uses, empowerment. A number of professionals, certainly during our last, say, 3 or 4 months, different professionals I came across occasionally would say, "Oh, it's amazing, I'm stunned that you're doing this." And I said, "Doing what?" And it was having Marmaduke at home. And they said, "Oh, most families wouldn't do that. Most people don't want to have their child die at home." But also, I'm not saying that was a general view, but I heard it so much. And so it really comes back to education. If the professional themselves are sceptical of a family being able to do it, if they're frightened, that communicates itself. So of course the family's going to be frightened, and therefore I can't do this. Whereas I think a lot of families potentially could. Empowerment, yes, it sounds like a motherhood statement, and there's probably many levels underneath it, but it's education. One of my youngest son had an extraordinarily profound conversation about death with his 4-year-old kinder class, to the consternation of parents who are watching it. But the kids were coming out with amazing things, and they were trying to comfort him and talk about grandparents they'd lost. So it can be done. It's actually the fear in the community that stops it.
The other thing I'd say is that I think knowing how to reduce suffering should be something that's taught certainly in the healthcare area at every level, so not just in this discussion about death and dying. And I think having uncontrolled pain is absolutely a medical emergency. It actually absolutely belongs in an emergency ward if that's what's happening and it hasn't been dealt with. And I think we underestimate the impact of uncontrolled suffering. And so that's something that is across the board. We need to learn how to manage uncontrolled distress, depression, pain. Any of those symptoms, I think, are as much of an emergency as someone having breathing difficulties.
Okay. Carmel, do you want to add? Or okay, it's covered. Question down here.
I just wanted to ask a question of Carolyn. How do you see the role of pastoral care?
I think that the issue of what's most meaningful in someone's life becomes very apparent when you're facing a major change, if you're facing suffering. And I think that one of the things that pastoral care workers do very well is enable that conversation around what is most meaningful to me in my life, and to assist people to actually articulate that. And to have the time to actually be with people in their suffering. I've worked with pastoral care workers who work on lots of different ways with different people. But that's probably the main thing. Is there anything in particular you were thinking in that question?
I was thinking more in line of, I find that there's a confusion with what pastoral care actually is, and people give a lot of, may give an emphasis on the religious rather than the spiritual support.
My experience, and I work in a Catholic hospital and we have lots of pastoral care workers, and they work with people with different faiths and with no faith, and it is usually more about what is deeply important to them and to their family. That would be my experience. Absolutely, there are some people who may be concerned that there's going to be a religious discussion, but I think anyone who's actually worked with pastoral care being an important part of their health service would probably not have that experience.
And I think from my perspective, I mean, again, whatever people call people, they might call them spiritual care workers or pastoral care workers, is I think in some ways they can break through the sort of hierarchies of the other health professionals, medicine, nursing, allied health. They actually start to give the patient their voice, because some people's voice has been very lost. It's been damaged, it's all sorts of things have happened to them, and they don't really give their real voice. And I think pastoral care has got this amazing ability to assist people to find their voice in some shape or form. And that can be through conversation, it can be through sitting by the bedside, it can be through physical touch, it can be through art therapy, it can be through all sorts of music as well, it can be through all sorts of mechanisms. So they offer a scope of practice which is under-recognised, I think, but from a palliative care team perspective is highly regarded. So again, it's working again in a faith-based organisation is where it is highly regarded. It's nice to see it in action day in, day out, but in other circumstances that can be a little bit disregarded, like palliative care, and you've kind of got to nudge people along to let that care come as part of the package. So.
Okay. Next question, up here.
Thank you. Half of my question's now been answered, to know that there's spiritual care and pastoral care as part of the palliative care team. I'd like to know what else is available in a palliative care team. And my second part of my question or concern is we're getting more and more single-person households. What's going to happen to those people? You talk a lot about family support of someone who's dying. I can see a future for single-person households which is absolutely terrifying when they get to that point.
Can we start with that second point first? I don't know if everyone heard, but the point's being made that a lot of people aren't in families, and more that's happening where there are single-person households, and that's a pretty terrifying prospect if what we're talking about is the huge role of the family in palliative care. Who would like to start with that one? Carrie?
In the days when I was working with the AIDS Council, and we would have young men dying at home, and we would have these rosters of volunteers, and I think we needed something like 21 or 28 people on that to cover someone who didn't have a family around. I think it's one of the big issues. I think socially isolated people, if I could build a community around each one of them, we would be halfway there. And I think we know that they don't do as well on nearly every level. I don't have a solution to that at the moment, but I do, I certainly know of a lot of services who are very creative in trying to get as much support in any way that they can to support isolated people. Can I just make one statement about your other part of your question? I think spiritual care is something that we all need to be doing. We know that patients in cancer centres want their oncologist, their cancer nurses, to actually care about what is spiritually meaningful to them. And so it's a conversation that is not just for pastoral care to be having. And again, it doesn't need to be a religious discussion, but for me to want to know what is important and unique about you and what your beliefs are and what your fears are is something that I think the whole team should at least have the curiosity to want to know and to know how to have those conversations. But yeah, I think isolated people is, as a community, we need to be working out how to embrace people that are isolated and are facing these issues.
Mark?
I think also, and again, it comes back to this early connector to maybe something like a palliative care as well as their treating care team in that sense, is that often that connectors within the hospital system can actually become those supports for a long time. And I think kind of nurturing that relationship can actually mean that for the majority of time people can be living in their maybe less connected home life and having their own apartment, as we're seeing in the city and things like that. But you know, there are times when it does become more difficult for people to be in that more isolated setting, but there are certainly mechanisms set up, and this is where maybe there are issues with development between the Commonwealth and the States, is that at the moment a lot of care packaging is tied up with the age determination of being over 63, 65, and we don't see those same care packages for people that come under that kind of age bracket. So there's a disconnect. So for older people that are more isolated, there's actually quite a bit out there to try and maintain people with those connections in the community. But I do think this interface between hospital and home is even more important, I think, for more isolated people, and that's going to put increased pressure, I think, into the future.
Carmel, you would have insight into this.
I think, look, our job is to accept people where they live and how they live and not make judgment. And we certainly have people who die at home alone, and they do that with our support, with neighbours sometimes dropping in. We use our patient volunteers in that area, but of course with all the OH&S in this day and age, you know, you have to do your risk assessment so carefully and make sure that that person that you're sending in there is safe. But look, we've had people who have died at home alone, happily, because that's where they've lived and that's where they've wanted to die. And all we can do is provide as much support as we can and support them in that decision. Sometimes it just can't happen, and it's about having that conversation with them as well, that I know that you want to die at home, but it mightn't be totally practical. So let's just take one day at a time, and we'll just get through 24 hours and then the next 24 hours. And it's just working with that person and trying to achieve their aims as best you can.
Any last
I
comment?
don't think anyone answered your question about who's on the team. And so it's chaplaincy, that's what we call it in the States, pastoral care, social work, because so much of serious illness care and suffering is socially determined, like we were talking about, nursing and medics, doctors. And then many teams have, in addition, for example, art therapists, music therapists, yoga therapists, that have a huge impact on quality of life and quality of care for patients. The problem is you have to raise philanthropy to pay for those things, usually. But they're very powerful and very helpful. We often involve physical therapy, occupational therapy, speech therapy, psychiatry for people who need that. So the team kind of forms itself around the assessed needs of the patients and family. Sometimes the most important person is the chaplain or the pastoral care. Sometimes the most important person is the social worker. It's a housing issue, it's a family violence issue. And sometimes the most important person is the doctor or nurse practitioner who knows how to do expert pain management. And we just sort of move in and out as different team members are needed.
We have time for just one very quick last question.
Okay, quick last one. There was mention earlier by Mark, I think it was, about developing a care plan. And as we get older, the documents are there, but the treatment that is requested by the person doesn't happen because and I'm talking about stopping aggressive action, not end-of-life action. Because sometimes the medical profession feels it must intervene, or they feel that that is not what the family wishes are. The family wants as much help for as long as possible. But me, the person who's requested at this level of whatever, I would like the treatment to stop and let me die peacefully. Who determines whether it is my wish that happens or whether it's my family's wish that happens?
Can I just direct that question to, thank you for your question, can I just direct it to Diane Meyer, but just because we're going to run out of time if everyone discusses it. Is that okay with everyone? Did you hear the question? Right. Sorry.
So, we are irreducibly social creatures, and our life and death affects people other than ourselves. And usually what happens when there's a difference of opinion between what the patient wrote when they had cognitive capacity and what the family is telling the doctors to do is a lot of conversation, a lot of working with the family to try to represent the patient as opposed to themselves, to try to imagine if the patient were sitting in the room with us on the chair over there, what would they say? And that works most of the time. When families are supported in a role of advocate for the sick loved one, as opposed to, families often are pushing for more treatment because they think that they will be judged if they don't, whether by other family members, by members of their congregation, by the daughter from California. And if you can help people understand that by validating, as a clinician, a social worker, a nurse, or a doctor, that the patient's wishes under this circumstance are sensible and that their job is not to worry about what the neighbor thinks. The job is to worry about and represent what they know their loved one would want. And those conversations are complicated and they require communication skills training. But usually we get to resolution, not 100% of the time, but most of the time.
Well, I'm sorry we do have to leave it there, but there are refreshments afterwards just out in the foyer there. But I'd like to thank you very much for being such a thoughtful and respectful audience and for coming out in this heat. I'd like to thank the Centre for Palliative Care for hosting this inaugural forum. And I'd really like to thank very much our wonderful panel who's really given of their time and expertise.